time. So anybody who is not comfortable with being recorded, then there's an opportunity to exit. But I think we'll all agree that it's a great value to have the discussions today recorded so that others can access them. So to briefly introduce you, this third series of Working to Health, from Crisis to Catalyst, is about future-proofing the public health workforce to provide and protect health, and to when countries are responding, and to ensure that they're resilient. It's hosted jointly by the World Health Organization and NHS England. And it's the third of a series of 4 seminars, the aim of which is to highlight the importance and the need for systematic health workforce development and strengthening. Each of these seminars have approximately an hour's worth of presentations, followed by an hour's worth of discussions, and your participation is incredibly important. I think there are over 600 people who've registered from many countries. We hope to have at least 300 of those attending in person. And each of the speakers will be asking questions, and we really actively encourage you to respond to those questions. So I'll be explaining in a little bit how you can respond to those questions using the chat function. So hopefully all of you will see that there is a chat box and a Q&A box that is on the bottom of the screen. And if you want to ask the speakers a specific question, then you use the Q&A function. But when each of the speakers will pose a question, which is to everybody who is attending, and if you can put your answers to those questions or your thoughts on those questions into the chat, that means that everybody will get a chance to see your ideas emerge, and it will promote a debate and reaction between the participants, which is incredibly important to make this a real dialogue. So the questions that each speaker will pose will be at the end of their presentation. So we encourage you to actively listen to what the speakers are saying, to think of any questions you have for them specifically, and then afterwards to reflect on sort of the questions that they're acting, so that we can stimulate this discussion. So we will have a series of 5 speakers. So the speakers today will be Laura Mangana, who's the founding president of the Global Network of Academic Public Health. We have Dr. Huan Hu, who's the coordinator of WHO's roadmap and on the public health and emergency workforce. We have Dr. Carl Reddy, who's the director of training programs of the Epidemiology and Public Health Interventions Network, or TEPINET, and Dr. Molent Okech, who's the Technical Officer of Human Resources. I'll introduce them all again immediately before they start to speak. And then finally, we have a video recording from Professor Kevin Fenton, who's the President of the Faculty of Public Health. But he will join us for the discussion part of the session. He is not able to join for the first hour. So really, without further ado, these series of networks are intended to stimulate a discussion because of the challenge of public health, which we've all seen through the COVID response. And so I think you're going to hear a series of incredibly stimulating presentations now on different perspectives on the public health workforce. And I'd like to turn first of all to Dr. Laura Mangana, who, as I say, is the founding president of the Global Network for Academic Public Health, which is an alliance of 7 regional associations representing schools and programs of public health workforce. So Laura, over to you.
Thank you so much, Neil. Good morning, everyone. Good afternoon, wherever you are. Maybe good evening, even. These times you never know. So thanks first of all for inviting me to participate in this very, very important seminar. as Neil was referring, I am now representing the Global Network for Academic Institutions, and we are representing 500 institutions in 100 countries. So in my capacity as president of the Global Network, I have had the privilege of serving as co-chair on the Technical Advisory Group, guiding the work on action area number 2 of the WHO Public Health Workforce Roadmap, which is focused on competency-based education. So today, I will be speaking to you about the roadmap and action plan, as well as briefly delving more deeply into the framework we have developed for action area number 2. Next slide, please. So why is this needed? We all know that the pandemic, as Neil was saying, exposed the weakness of the health systems worldwide and has provided new impetus for strengthening health systems, revitalizing essential public health functions, and enhancing emergency preparedness and response capabilities. It also reminded us of the interconnectedness of the health, social, and economic systems. So strengthening health systems that address the social determinants of health requires a resilient public health workforce at the helm. That is why the Global Network of Academic Institutions supports and works very closely with WHO in preparing the workforce we need to address current and future challenges. In this regard, we strongly support the WHO roadmap just because it offers a blueprint for countries to assess themselves and develop action plans to build capacity of the workforce which delivers the essential public health functions. As a global network, we believe countries can learn from each other, and regionally, there can be increased collaboration to pool resources and expertise. This implementation can be enabled through evidence-based guidance and innovative and disruptive ways of thinking to reassess public health education, research, and practice. By establishing well-defined competencies for public health personnel, we can work more synchronously and effectively to protect the public's health and improve confidence in times of misinformation and distrust. Next slide. Our shared vision is to strengthen the public health workforce in every country, one that is capable of successfully delivering the essential public health functions, including emergency preparedness and response. The public health workforce is at the core of the health system and all essential health functions as well. So operationalizing the roadmap has the potential to tremendously strengthen the health systems of countries around the world. 3 fundamental principles we are supporting. Number 1, competency-based education. Number 2, preparing the workforce to effectively and efficiently implement the essential functions of public health. And number 3, the alignment between academia and practice. Next slide. The workforce is dynamic and comprises not only health and care workers, but also personnel from a range of allied occupations. So for us, the workforce is basically incorporated into 3 groups. The core public health personnel. Number 2, the health personnel that perform one or more of the public health functions. And number 3, personnel from other allied occupations that directly or indirectly influence population's health. Next slide. The conceptual approach. There are 3 action areas in the roadmap. In the first area of action is the definition and the functions of the essential functions of public health, which I will refer later. Number 2 area is the competency-based education. And number 3 is the mapping and measuring of the occupations. In the next slide, we're going to see that under action area number 1, thank you, the WHO and its partners identified 12 essential public health functions. You see it here on the screen, which are listed here. As part of the roadmap, a technical package of tools has been prepared to guide operationalizing the essential public health functions, which lays out their sub-functions as well as a strategy approach for their delivery in a national context. In addition, a comprehensive step-by-step approach is provided to support operationalization of the essential functions in a manner adaptable to different countries' contexts. This includes defining public health services, strengthening institutional structures and workforce capacity, and identifying strengths and gaps to inform policy and planning. In the next slide, in action area number 2, which is focused on competency-based education, Through analysis of the existing frameworks and extensive consultation and engagement by the Technical Advisory Group, our work has focused on developing a modular, foundational tool to guide educational program design, one which can be adapted to varying contexts, various contexts and learning needs. The framework addresses the two overarching questions for action area number 2, which were what are the competencies required to deliver the essential functions of public health, and how should education and lifelong learning materials be designed and delivered? In response, the framework sets out the practice activities, competencies, and guidance, the contextualization of all of them. Next slide. Competencies, we define competencies as a person's ability to integrate and apply relevant knowledge, skills, attitudes, and values demonstrated through behaviors. In the framework, which, by the way, it's already available, and we really encourage everyone to use it and to get to know it, the framework identifies 20 competencies essential for effective public health practice, organized around the 6 domains that you can see on the screen: communication centeredness, decision-making, communication, collaboration, evidence-informed practice, and personal conduct. These competencies were identified in relation to the practice activities towards delivery of the essential public health functions and are relevant to the 3 groups of public health essential workforce frameworks that I was referring before, which was the public health, like the core personnel, but also the clinical practitioners and occupations that are related to health. You can see here that also are not only the competencies, but also the behaviors. So it's a very comprehensive document. The next slide, thank you, is there right here. There are the practice activities. Thank you. So the practice activities are organized into 5 domains. So we went beyond the competencies and the behaviors, and now we are describing the practice activities. These practice activities are organized into 5 domains that you can see on the screen, each with practice activities and a list of associated tasks, where there are also defined tasks for each of these activities. So performance of each practice activity is enabled by application of the competencies demonstrated through behaviors. So 40 total identified practice activities, which take the essential functions and translate them into tasks and activities an individual can conform. So there are 5 elements to each of the practice activities to support the development of the curricula: public health impact statement, essential public health sub-functions directly supported by the practice activity, the range of tasks towards the practice activity, illustrative profiles, we included that. There are examples, sets of tasks, and relevant knowledge that you can use and apply and adapt. Curricular guide, key areas of knowledge and skills. The content is by no means exhaustive, nor it is prescriptive. It is offered really as a guidance, inclusive of the workforce, all career stages, teams, and contexts. Is for everyone to look at them and adapt it and adopt it and just take whatever they need in order to really strengthen the workforce capabilities. In the next slide, the action area number 3, that work stream, we're working to standardize approaches to mapping and measuring occupations engaged in delivering the essential public health functions. There is a pilot already underway in select countries with expression of interest from numerous others. So as we move forward, guidance will be developed to profile and enumerate the public health workforce so that we may better capture the range of occupations involved, the sub-functions they perform, and how the roles and responsibilities relate to specific essential public health functions. Next slide. The way forward. Looking ahead, our detailed 2-year plan of action running through 2024 will focus on developing the tools and guidance needed to support country application, contextualization, and benchmarking of all 3 action areas. In addition, we have defined target set of 5-year period, 2022-2027, which outline the intended expansion of country-based application. Next one. So in the face of the pandemic and other persistent and emerging health threats, we are more aware than ever of the need for a trusted, well-established public health workforce. one with adequate capacity and effective coordination to provide expertise at local, national, and international levels. So we believe that this roadmap is intended to pave the way for the development of competent public health personnel who can expertly deliver the essential public health functions in ways adapted to their individual context and will, we hope, serve to establish more resilient and well-supported health systems globally. The last one, from all of us at the Global Network for Academic Public Health, and on behalf of the WHO, in the next slide, please. The WHO, the Technical Advisory Group for Action 2, we want to thank our numerous partners for their continued support of an engagement in this important work. So we really encourage you to really read through it. It's extensive, it's comprehensive, but I hope that can be of a lot of help for all the countries. As Elisa, we need to hear from them. And my question is, how do you see just engaging in the implementation of the roadmap? So thank you, and I'm looking forward for the Q&A.
Thank you very much, Laura. So an important question there. But actually, if you could just stay online for a minute, I had one question around, you mentioned the partnership that is supporting the roadmap. And obviously, you represent a network of schools of public health. So people will be aware that schools as educators of the future public health workforce play an important role. What value do you see in the collaboration between schools and the network in terms of propagating these ideas so that we have a greater standardization of approach globally?
Absolutely. Oh, it's tremendous. We really need to work collaboratively on this. We see a tremendous value in both sides, like the education and the practice. Why? Because more and more we are working into the workforce space arena in the lifelong learning, meaning that we need to be working a lot with the updating the skills of the workforce that is already working. So that whole space is where we interact, like the National Institute of Public Health, the schools and programs of public health, and the ministers of health. We all put together courses, we all put together curricula in order to update the workforce. So this is really a perfect timing to work together. Now we know what to do. There are the competencies are there, and it's a very comprehensive work. The competencies, sub-competencies are the practice, are the behaviors, are guiding tasks, are provided. It's a lot of material there. It's enough material, I would say, in order for us to be working now in a country level, in a regional level, in a level, or in a local level, in order to see from all that material what we can put together as a curricula and trying to put educational materials in order to update our current workforce, but also the workforce that we are training in the schools and programs. So it's the perfect timing for that. Thank you for the question, Neil.
Thank you. Yeah. So briefly to summarize, we can see that there is a well-established structure and an approach which can be used by every country in order to understand its existing workforce capability, understand the approaches to training and capacity building, and to begin to plan for expanding that workforce. But the beauty of this approach is it draws upon the capability that already exists. So schools and institutes of public health collaborating to develop a workforce. And that's an approach that's been very much developed by and supported by WHO. So it gives me great pleasure to move to our second speaker, Dr. Juan Zhu, who is the coordinator of WHO's work on the roadmap on the public health and emergency workforce. So I will hand over to you now, Juan.
Thank you, Neil. We just say hello from WHO headquarters, and our job, the roadmap, is a joint effort by WHO and its global partners. And this is leading by Health Workforce Department Director Jim Campbell. My colleagues here, Lizzie Tenson, Miss Lizzie Tenson, accompanying with me now, would like to say hello to all of you. Taking this opportunity, we would like to thank all the partners for their great contributions. And these, as one of our partners, Laura's presentation provide the key points of our roadmap. So my presentation will mainly focus on the operationalization phase of benchmarking in 100 countries from perspective of a general coordination, provide the complementary information. Next slide, please. So here is a brief background. I would very briefly, globally, the COVID-19 has exposed the weakness in every national health system, public health, and the roadmap is the result from the G20 Italian presidency political declaration and series of World Health Assembly resolutions. In order to build resilient national health system and public health, we really need to strengthen the capacities of public health workforce. From our observation, each country is in the process of reviewing and establishing well-defined capacities for public health personnel. As a result, the roadmap was launched in May 2022, and this is the 5-year initiative. Later, the 2-year action plan was launched. By these links below, we can access the multilingual roadmap and action plan. Next slide, please. And the benchmarking is the first step to implement roadmap. It is based on the country's public health priorities and needs. Laura's presentation mentioned there are 3 action areas in our roadmap, prioritized by the roadmap. And our approach of benchmarking is modular. Countries are encouraged to pick the action area under their individual context and priorities. Our technical teams can plug and play into this approach for specific functions, specific events. I would like to clarify here, the 3 action areas are interlinked, but it is not necessary to be consequential. So the benchmarking can be entry in any order or in any combination of the action areas based on the country's needs. As a result, the benchmark findings are the workforce data to inform countries' national public health workforce strategy or national health security plans or national public health institution plan. Next slide, please. Here is the benchmarking for action area 1. There are 3 steps to implement. First, population health needs assessment and risk profiling. Second, strategic review of baseline capacities for delivering essential public health functions. 3, acting on key areas and developing sustained public health capacities underpinned by the EPHF. During the process, there are enabling factors for this benchmarking. Next slide, please. So here is an example to do the benchmarking in the country, in Ireland, actually, for one of the functions. We don't need to pay much attention to the details. We just show you the framework of the benchmarking. Next slide, please. So we are developing technical tools for each action area. Now for the action area 2, the technical tools focus on the operationalization of competence framework to review, benchmark, and strengthen public health education and training to meet national public health requirements. The result of benchmarking of action area 2 will be linked to the education system, employment system, and the political consensus. For example, in the education system, benchmarking will help us to get the rational basis of developing curriculum, and also to help us to identify the learning needs, including knowledge, skills, attitudes, behaviors to fulfill the functions. Next slide, please. So now is the action area 3 benchmarking, and we can see we already developed the technical tools to cover the benchmarking of occupation mapping of public health workforce step by step. Next slide, please. So now we will show you the pilot countries, current pilot countries and the status. The countries we can share with you: the Colombia, Georgia, Ghana, Kenya, Uganda, England, Utah, and Ireland, Azerbaijan. This is dynamic, might not include all the countries under the pilot projects. And we divide the pilots into at least the 8 steps. Next slide, please. So from the pilot countries and activities, we really learn the lessons. For example, the countries understand the importance of the roadmap benchmarking is really important for getting the strong support and buy-in. And for the national implementation team already exists, needs to be expanded and diversified. In some countries, they have very strong national association across partners. And in some countries, they already initiated similar work or initiatives. So I would like to clarify the benchmarking of roadmap would not start from the scratch. The benchmarking process will be built on the existing ones. And we would not reinvent the wheel, actually. Next slide, please. Here we show you additional expressions of interest from the countries across 6 regions, WHO regions. You can see, and we are looking forward the joining of more and more countries. Please remember our ambitious target. Until next year, July next year, we would like to implement the benchmarking in 100 countries. Next slide, please. So here is the flowchart about end-to-end process from the expression of interest to benchmarking. Any given stakeholders or in any given countries would like to join. If you like to join the roadmap benchmarking, we encourage you to send the email to our SharePoint team email address, phewf.roadmap@who.int, or you can reach out to any technical officer lead in the action areas, and at the same time copy us by these SharePoint emails. And then we will organize the following communication meeting between the country focal point and our partners, for example, the GNAP, the IANFI, and the World Federation of Public Health Association across the globe. And based on the preparation and logistics, we can conduct the field validation and benchmarking. And the finding of benchmarking would be data report and recommendations. Based on the findings, the country can conduct the policy dialogue across the multi-sector partners and integrate the outputs of the benchmarking to the national health security plan or any other public health workforce strategy. Next slide, please. So I will stop here. So remember to send us the email by this SharePoint team email address. Next slide would be a discuss question for all the audience. The question would be, how can WHO and partners work with countries to best adapt to country context and assist the countries in their needs during the process of strengthening national health, public health, and emergency workforce? Thank you. Thank you all. Thank you, Neil.
Thank you very much, Juan and Lizzie, for that contribution. So I think that moves us nicely along this story. We heard first of all from Laura about the elements of the roadmap and how existing networks are being drawn in partnership. And we see underneath your slides the list of some of the partners who've been actively supporting that network. And then we've heard from you just now the ambitious targets that WHO have set for 100 countries to have embarked on a process of mapping and measuring and supporting and strengthening their workforce. And I think you've set out nicely how countries can engage in that process and embark on it. So the first question that Laura asked was how countries can engage. And you're now asking countries the second question, and hopefully people will respond in the chat how they think that it would be useful to adapt and adopt the various tools that have been developed to support the roadmap in order to engage in the process. So thank you very much for that. And that then takes us on nicely to our next presenter. TEFINET is one of the partners of the network, and I'm sure Dr. Carl Reddy will explain some of the background and the interests of the TEFINET program. But Dr. Carl Reddy is the director of the training program for epidemiology and public health interventions network at the Task Force for Global Health. And I think I'm going to see you in a week or so's time with an important launch of a global field epidemiology partnership in Berlin at the World Health Summit, Carl. So maybe we'll have a chance to talk about that later as well. But over to you now.
Thank you very much, Neil. And thank you for pointing out, the links between the various partners and how their needs are being addressed, for example, by the development of the WHO roadmap and including the work of Kasum Diallo. So my presentation is from the point of view of TEFINET, which is the global network of more than 85 field epidemiology training programs. And it's titled FETPs and Planning for the Public Health Workforce. Next, please. So just a little bit of context to understand what these FETPs are, the 85 of whom are members of TEFINET. In 2000, the Center for Disease Control here in Atlanta introduced 3 tiers of field epidemiology training that offered countries training options tailored to the skills needed at different levels of the public health system. The added options, as presented on the table on the slide, present opportunities to differentiate the program duration, the cohort size, and whether it is full or part-time commitment. You will note that the FETP training is a pyramidal model. At the top of the model, you have your 2-year advanced training. I remember a question in the chat asking about practical experience. This FETP training is premised on field work, on field exposure. So there's a learning component, a classroom component, which is not more than 25% of the training time, and the rest of the time is spent in the field, gaining practical experience and actually applying what was learned in the classroom. So there's the advanced level, which is of 2 years duration. There's the intermediate level in the middle of the pyramid, which is between 9 and 12 months. This is a part-time training course that allows trainees to remain in their work positions and attend modular-based learning for a week at a time over 9 to 12 months. And at the bottom of the pyramid, you have the frontline training, which is about 3 months duration and consists of about 2.5 to 3 weeks of face-to-face learning in a 3-month period. And as you can see from the table, these different levels of training prepare the public health, prepare field epidemiology workforce for different, for district, regional, and national levels in their respective countries. Next, please. Okay, so what is the value, you might ask, of this FETP cadre, right, which has been in existence since 1951, when US CDC started the first such program called the EIS program here in the United States. These trainees strengthen public health systems and they advance health security. How do they do so? They are adept at setting up new surveillance systems and evaluating existing surveillance systems for communicable disease as well as non-communicable disease. They are well trained in outbreak investigation, in hypothesis-driven research, and in operational research. The graduates and the trainees provide mutual assistance in response to international outbreaks and other public health emergencies, such as natural disasters and humanitarian crises. And thirdly, they are trained in the management of specific epidemiological challenges and other projects. Next, please. From this graph, you can see the rapid growth in the number of individuals trained in these FETPs. You will see that for the frontline level, the bottom training level of the pyramid, how the number of trainees increased 385% from 2014. And you will notice how the intermediate level increased by 132%, whereas the advanced level increased by 84%. And why is this the case? You will note that from 2014, we've had various international public health challenges, such as the Zika outbreak, such as Ebola, and most recently with COVID-19. During each of these outbreaks, countries that didn't have FETP training requested expansion, requested frontline training in order to prepare staff of the Ministry of Health or the National Public Health Institute to deal with the current outbreak, hence the rapid expansion of frontline in the light of these public health emergencies. Next, please. So the field epidemiology training programs and TEFINET and various partners and stakeholders realized that there were inherent challenges in the training model. These challenges needed to be addressed to ensure that FETPs had a standardized curriculum, that they were appropriately training their trainees in a standardized manner, that their trainees were indeed able to address those challenges of outbreak investigation, surveillance system evaluation. And the vision was that every country in the world should have the applied epidemiology capacities needed to protect and promote the health of its own population and to collaborate with others to promote the health, to promote global health security. So in view of this, TEFINET called together a meeting of key partners and stakeholders that was held in Bellagio in Italy in 2018. There was a follow-up meeting in Geneva 2019. Next, please. And what actually happened at these meetings was that partners and stakeholders drew up a roadmap to take the whole FETP enterprise. When I talk of the enterprise, I'm referring to all the FET programs, to the regional networks, to TEFINET, the global network, to everybody involved in this global effort to train field epidemiologists. And keeping the vision in mind, it was decided to develop a strategic leadership group to take this whole enterprise forward and address some of the challenges with field epidemiology training that had been identified in the meetings in Bellagio and in Geneva. Next, please. So what were some of these challenges of FETP that were related to workforce development? I mean, there were numerous challenges. There were challenges related to the rate of FET expansion. that FETPs were growing too slowly, and many countries did not meet the target of having one epidemiologist at least per 200,000 of the population. There were questions about the quality of training in many programs. There were questions about the curriculum not being up to date or not being as relevant to the needs as it could be. But when it came to workforce development, clearly some of the challenges were a lack of clear roles and definitions for epidemiologists within national workforce plans. And of course, this would have and does have an impact on sustainability of the training programs, because then it's more difficult to recruit trainees when their roles and definitions are not clear in workforce plans, when there's no clear career path for such trainees and for the graduates. So clearly there was a need to define and develop a career path for applied EPIs. And finally, it was necessary to get recognition for the job title or profession of epidemiologist by the International Labour Organization. Next, please. So this strategic leadership group that was formed to take the FETP enterprise forward developed 8 recommendations on how to strengthen the field epidemiology training enterprise. And I'm just highlighting recommendation number 3, which is relative to workforce development. And it states that the strategic leadership group should promote the development of applied EPI workforce targets. So let's have a look at how this was done and what TEFINET's involvement was. Next slide, please. So the strategic leadership group, in order to take the 8 recommendations forward, formed working groups, 1 working group per recommendation. The working group for recommendation 3 had consultations with key partners at the WHO, CDC, obviously TEFINET was involved, and AFINET, the regional FETP network in Africa. And it was then agreed that the work of working group 3 to take that recommendation forward would tie in with a project led by Kasum Diallo of the Health Workforce Department at WHO HQ. And as part of this project, there was the development of a tool for applied epidemiology workforce mapping, right? Targeting the health workforce. Because clearly, one of the recommendations from the FETP roadmap was to expand FETP training so that every country could have the capacity to address its public health challenges and its outbreak challenges. And in order to do so, you have to know what workforce for field epidemiology currently exists in country in order to plan and to obviously train more people in order to meet the target of 1 per 200,000. This slide has been shared coincidentally by the 2 previous speakers. I'm not going to go into detail, but you can obviously see the diverse workforces that actually contribute to the essential public health functions, right? Next slide, please. Okay, so what is this mapping and measurement of field epi workforce or epidemiology workforce in country that needed to be done? In simple terms, it's a process by which countries understand the size and profile of their national workforce in epidemiology or field epidemiology. And national job titles are mapped with the International Standard Classification of Occupations of the International Labour Organization. And then clearly, once this is done, you can identify what the gaps are in your workforce capacity pertaining to epidemiology or field epidemiology. And then finally, this data can be used for workforce planning going forward and for policy making. Next, please. Okay, so why is this mapping important? It's always useful to know the size and profile of a particular workforce, particularly when this is compounded by a lack of standardized definitions and limited data availability, even in high-income countries. As we saw from the previous slide and previous speakers, the public health workforce, the workforce that conducts the essential public health functions, is a a heterogeneous workforce, right? You need personnel that are multi-skilled and perform multiple functions. And of course, they have differing educational backgrounds and job titles. And as we saw, they come from health plus the non-health sector. So for example, environmental health officers will play a key role in outbreak investigation and in pandemic preparedness and response from a One Health lens, are often employed by another sector of the government, beyond the health sector, the environmental sector. Thirdly, classification, occupational classification remains unaligned in many countries of the world with the international standard classification of occupations. So there's a fundamental measurement gap. And there's a wide variation between countries. So in many developing countries, within the ministries of health and national public health institutes, there isn't a job category, there isn't a job position called field epidemiologists necessarily, or epidemiologists. So graduates of FETPs end up working under many other job titles. Next, please. Good. So what is the way forward? As we've seen from a previous speaker, the technical guidance that was developed by this working group 3 of the strategic leadership group of TEFINET, obviously working very closely with Kasum Diallo and his team at the WHO Workforce Development Branch, developed some technical guidance, and this guidance is being piloted in 7 countries. I'm not going into detail into this because it has been covered. The methodology and tools were iteratively refined and finalized, and clearly country support was very important and provided by all partners. And there is ongoing work, and the pilot is hoped to be completed by late January 2024.
Thanks,
Next.
Carl. Yeah.
Thank you.
Oh, if you just want to ask us your question, Carl.
Yes, and the question that I had is, what is the importance of mapping and measuring the epidemiology workforce? Thank you.
Thank you very much. And that's a really useful example of one of the important categories within the public health workforce. And I think this demonstrates the value of this partnership, which has brought together a number of different agencies. And it highlights for me that there is no single professional group that has the exclusive responsibility for delivering public health, but we need to ensure that the full range of public health capabilities are delivered to ensure we can deliver the essential public health functions. And clearly, epidemiology is a vital resource. So Carl's third question adds to those that you should be addressing in the chat function. Try to respond to that question, and we'll stimulate that discussion, which we'll pick up later online. I now want to move on to our fourth speaker, Dr. Molent Okech, who is joining us despite it's the middle of the night in Papua New Guinea, and there's power shortages. So congratulations on managing to get a connection to join us, Dr. Molent. Dr. Molent is the Technical Officer for Human Resources for Health, as well as the acting team lead for universal health coverage, stroke and health system strengthening and healthier populations in Papua New Guinea. So clearly a very busy person, but without further delay, over to you, Dr. Molent.
Thank you. Thank you, Prof. Neil. Thank you, colleagues. Good morning, good evening, good night. This is building on what my other panelists have discussed, and this is one of the countries that will share experiences of what they went through because of a weak public health system. Next slide. So Papua New Guinea is a country of a population of 10.3 million, with a life expectancy of 69 for the females and 64 for the males. Most of the population, that is 80 to 85%, live in the rural areas. And PNG is such a diverse country with over 800 languages and distinct tribes. So you can see it is number 156 out of 191 countries in terms of Human Development Index. So this is a country that got its independence in 1975 and has a constitutional monarchy with national parliament elected on 5 terms, with 20 provinces and a national capital district, with the region of the autonomous region of Bougainville, which wants to secede from the wider Papua New Guinea. The discussions are on. So Papua New Guinea is a small island developing state, and they have several sustainable development challenges, including small populations, limited resources, remoteness, susceptibility to natural disaster, vulnerability to external shocks, and excessive dependence on international trade. So currently we are on blackout because there was a volcano eruption and it has affected a lot of the systems. Next slide, please. These are some of the indicators, the socioeconomic indicators. You can see the literacy levels are at 58% for female adults and 65% for the males. Our population growth is 2.0 per year, and we have a poverty index of about every population, there is about $2.15 US a day per poverty headcount. Then we have under 5 mortality at 79%, at 79 per 1,000 live births. So it's a country with a lot of challenges, and you can imagine when an emergency strikes. Next slide. You can see the country has a high burden of disease, both communicable and non-communicable diseases. We are ranked number 160 out of 161 countries in the UNDP Gender Equality Index, with high rates of sexual violence against women and girls. TB incidence rate is quite high at 441 per 100,000 population. It's one of the highest globally and the second highest in the WHO Western Pacific region, according to the Global TB Report of 2021. Papua New Guinea has also premature mortality from non-communicable diseases, which is growing fastest of all the WHO Western Pacific region. You can see on that index down there, it's one of the countries with a high increase of non-communicable diseases. Next slide, please. Next slide. Thank you. High burden is intensified by low rates of health service coverage. We have very low, 40% of births are attended by skilled personnel. 50% of pregnant women attend only one of the ANC visits. And in most provinces, average person has less than 1.5 outpatient visits per year. And this is because of several reasons. Next slide. This country has scarcity of healthcare workers as well as medical supplies. It has the lowest ratio of healthcare workers in the Western Pacific region of 0.587 healthcare workers per 1,000 population. In no province, there are all provinces, basically you can see there is stockouts of medicines. Almost 40 months lack of medicine. Then in most provinces, you can see only 40 outreach clinics per 1,000 children. So those are some of the challenges. Next slide. So challenges in accessing health have so many issues. One is the geographical barriers. PNG is a country with a lot of islands. Financial barriers are a challenge. The stigma, gender-based violence and injuries, drowning, it's in the Pacific. Health literacy is a challenge to accessing health. Internally displaced persons. From time to time, now and then you find a lot of clan clashes, fights, inadequate health workforce, and in some places, there is none. Next slide. So you can see these are provinces in Papua New Guinea with limited network, severely compounds difficulties in providing health services. But in all that, you can see the beauty and color in Papua New Guinea in those pictures. Next slide, please. So this is the crisis. With only 18,986 health workers, the COVID-19 pandemic highlighted a severely under-resourced healthcare system. COVID-19 exerted unprecedented pressure on an already weak healthcare system. The pandemic triggered an abrupt new demand for care for COVID-19 patients in hospital emergency departments and intensive care units. The pandemic exposed the weaknesses and raised concerns among the communities and the policymakers. A weak PHC system to provide health promotion and preventive services. There was weak community engagement and resourced health systems with low supplies and equipment, and many health workers emerged from the pandemic exhausted with intentions to leave their positions. Next slide. What did we do? During this time, this is the time when the country needed people with some knowledge on field epidemiology, like my colleagues have said, how they are very important in such moments. The importance of healthcare workers came to the limelight with a call to invest in national workforce to promote health, treat illnesses, and respond to emergencies. Designing an education to equip healthcare workers with the knowledge and skills to meet essential health needs and emergency preparedness. Understand the composition of their health workforces to address gaps and shortages in a health labor market analysis and national health workforce accounts. The previous panelist has just posed a question: what is the need of mapping? It was necessary at this point that the country mapped the health workers using the national health workforce accounts and the ISCO 08 coding. Defining essential public health functions and mapping occupations for strengthening through competency-based education. Strengthening collaboration and partnership led by the National Department of Health, and there was also stewardship from the national department or the national government. Next slide, please. So within that period, the country was able to revise their National Human Resources for Health Strategic Plan 2021-30, and it's also aligned to a national health plan that was developed within that period, because the health workers is quite necessary for the plans and the strategies within the national health plan to go hand in hand. So they were all developed at the same time with a need to think of the next generation of health workers that will withstand the shocks. Next slide. Next slide, please. So catalysts for the future. One thing, PNG is aware that whether the current situation is a problem or a challenge, every problem has a solution and every challenge brings with it an opportunity. Therefore, life has a way of fixing the imbalance. There were so many imbalances during the strike, and at the end, there were significant investments in physical infrastructure, equipment renovation, and ICU beds. There was recruitment of more than 7,130 healthcare workers and creation of a new cadre called the Village Health Assistants. The legal reform for emergencies by establishing emergency operations centers, investment in essential health workforce for effective response to public health emergencies, maximization of the nexus emergency development to strengthen its health system, making it capable of protecting its people and its economy against major public health threats. Next, last. So these are the key messages. The country is very clear currently. They're addressing health workforce shortages by investing in education and training to avoid future shortages and increase preparedness for future shocks. Increase retention rates by improving working conditions and pay rates for categories of workers that have traditionally been undervalued. This is a country we cannot purely have epidemiologists, but we have mapped up a few of the cadres that exist, like the nurses, the health extension officers. We are enlarging their jobs with competencies to be able to address public emergencies. Increase staff recruitment to reduce the workload and pressure on the existing staff, so that those who are willing to leave at that particular time are willing to continue to stay in the work, please. Next slide. This is my question. Are the health workers from small island and developing and fragile states like PNG prepared to adequately respond to another pandemic or health emergency?
Thank you so much, Dr. Molland. That was an excellent presentation and really highlighted the fact that in spite of the many challenges that you face in Papua New Guinea, there has been incredible progress on sort of, developing and taking forward the roadmap. So really good to see, and important questions which hopefully people will have a chance to respond to. We'll condense the response to 10 minutes, so we still have time now for Kevin's presentation. So without further ado, I'll quickly turn over to Kevin, who will be joining us later for the Q&A session. But if we can go straight into Kevin's presentation, please. The professor.
Hi, I'm Kevin Fenton. I'm the president of the Faculty of Public Health. I'm so pleased to be able to give this talk today, although I'm sorry I'm not able to be there in person. I'm going to be reflecting on working for health for 2030, building a health workforce leadership. And in the time that I have available, I'm going to touch on 4 key areas. First, the importance of public health as part of our defense infrastructure and how we need to reconceptualize our public health systems. Second, to reinforce the pillars of public health and the importance of developing integrated and collaborative systems. And finally, reflecting on the future of public health and how our systems need to be agile and adaptable to take into consideration both opportunities and threats ahead. So as we think about resilient systems and healthy societies, I would like to propose that having an effective public health system should be at the core of this foundation, giving societies the ability to respond to a broad spectrum of threats. Reconceptualizing public health systems as a critical part of our overall defense infrastructure is critical. It's certainly a lesson that we have learned and hopefully a legacy that we have achieved as we've emerged from the COVID-19 pandemic, a legacy in which implementation of emergency public health functions is seen as one of the most cost-effective and sustainable ways of enhancing and protecting the health of populations. Now, this reframing of public health systems is important because if we fail to invest in effective health protection systems, and if we fail to work with our domestic and international partners, then ultimately it places our societies and communities at greater risk and is a failure in national defense. And as we think about what's required for a well-functioning health protection system, I would argue that it is one that inspires confidence, that engages effectively at local, regional, national, and international levels, and one which is really focused on building and tackling low levels of trust that we have seen both in communities and across partners, which can be a real driver in the failure of technically competent systems. Now, the pillars of public health practice are well known to many of you in the audience, and they're here, the 10 essential public health services, to remind us about the components of effective public health systems and why that investment is not only on the workforce, the ways in which we deliver public health programs, the importance of policy development, and the importance of assessment, evaluation, and learning. All of these key pillars of public health services need to be in place to ensure we have robust systems. And a key factor underpinning robust systems is the public health workforce. And by this, we both reflect on core public health personnel, those who are trained in public health and who assume leadership positions within societies to deliver public health programs, design public health systems, and engage with political colleagues. But we also think about the public health workforce working in the health and care system who may perform one or more public health functions, and also allied professionals working in other occupations and in other systems, which also interface with public health practitioners as well. Understanding the broad conceptualization of the public health workforce, investing in their training, capacity development, as well as their career progression and opportunities becomes part of ensuring that resilience within the workforce and resilience within public health systems, which are required. So framing public health systems as a key part of our defense infrastructure is important. Ensuring that we have investment in all of the pillars of public health practice, focusing on developing the public health workforce will be key in our journey towards 2030. Now, public health systems don't exist in a vacuum, and a key lesson that we've also taken away from the pandemic response is the importance of integrative and holistic systems. I would argue that an effective public health system must be able to work with partners across civil society in order to deliver on these essential public health services. We must be able to have strong partnerships with first responders, with policymakers, with politicians, the voluntary sector, a range of other professions and professional associations, and many others. And in this context, partnership working is key. There must be clear lines of accountability and communication, enabling the public health system to effectively interface with other systems. And we need to ensure that in assessing risks and preparing for risks, we do so in as broad and holistic and integrative way as possible. So we're looking at ways in which we tackle multiple concurrent threats, whether from disease, climate change, rising NCDs, global violence, antimicrobial resistance, all of which require coordinated efforts, both at the global and national and local levels. Now, as we think about the resilience of our system, as we think about how we invest and how we create integrative systems, we need to also think about ways in which we need to adapt to respond to new threats and new opportunities to public health. So a key part of coordinating our systems and response is how we use latest technologies and research. And clearly in this space, digital innovation, genomics, artificial intelligence, predictive data, and other technological developments are all going to have a huge impact on the way in which we practice public health, whether in health security, health promotion, or the work that we do in healthcare systems, but also will have an impact on our health protection interventions as well. Digital technologies and artificial intelligence are providing powerful new resources for us to both characterize, enhance our responses, to think about recovery in new ways. And it's also helping us to train and develop our workforce to create much more resilient and trained and better capacity workforce in the public health practice as well. So these technologies, I think, provide lots of great opportunities for us, and we need to work together to think about some of the challenges, whether in terms of how they're applied ethically or the policy questions that may arise. So in closing, I think what I want to do today is to reflect on the opportunities that we have as we think about 2030 workforce and building resilient health systems. I've discussed some of the key components of why we need to reframe the importance of public health systems in society, the core components of the investment in those systems, whether looking at the pillars or workforce or ways of working, and also thinking about the new opportunities and threats that may present themselves. So I end by asking this question: how can we responsibly harness the power of these emerging technologies to support our global public health systems and workforce? What are some of the opportunities? What are some of the challenges? And how might we work together to address them? So with that, thank you so much for inviting me to give this brief presentation, and I look forward to hearing the results of the discussion and deliberations.
Thank you very much. And Kevin has been able to join us because we're running a little bit late, Kevin. So good to see you in person, and great that you will be here for responding to some of the questions that have been asked. So obviously we've had a series of 5 questions that have been asked, and I'd like to encourage people as we begin this next session to continue reflecting on those 5 questions, but also to continue asking questions to the individual panelists, and those will be fed up to me to ask to the panelists as we go by. But what I wanted to do quickly was just look at the team behind the scenes have been identifying some key themes in relation to each of the questions that have been asked. But I'll start quickly just by summarizing for the discussions we've had. We've heard how a range of different partners are supporting and developing the tools for developing the public health workforce, with the presentation from Laura and the global network of academic public health. We've then seen how WHO has utilized the political momentum that arose from COVID and discussions had at the G7 and G20 levels to develop a roadmap with a high level of ambition of reaching 100 countries. We've then heard how individual professional groups and their representatives, as spoken about by Carl Reddy, have ensured that they're aligned with this roadmap, and that specialist professional groups such as epidemiologists are an integral part of this process. And then we've heard a very real and live example from Papua New Guinea, from Dr. Mollent, of how these challenges are being applied at a country context to map and measure the workforce. And then we've been asked some very important questions about how we ensure that we systematize our public health development, and also draw upon the new opportunities, with a key question on how we enhance technology and understand the opportunities as well as the threats that are offered by many new challenges. But Kevin usefully highlighted as well the new challenges that face all public health systems, with the rising challenge of things like climate change, which will just exacerbate the many other issues that we face. So looking at the key themes that emerge from questions, somebody has highlighted that the roadmap is the elements are interlinked, but they aren't necessarily sequential. So although 3 steps were highlighted, they don't have to happen 1, 2, 3. They can all be occurring at the same time. And I think Dr. Bollard illustrated that. Somebody else has highlighted that benchmarking is crucial, and it should be across different stakeholders and occupations, and encouraging buy-in. This point about not reinventing the wheel was recognized as being very important. There was acknowledgement in the comments that this is a very ambitious target of trying to reach 100 countries, but we've seen from Papua New Guinea that with ambition, then achievement is possible. There was also a comment on international pharmacy teams being included, and speaking to the wider remit, also looking at laboratory experts and others that could be brought into this workforce. And there was a question about whether WHO support includes financial and technical support. We know it includes financial support, but there are other instruments such as the newly developed pandemic fund and national level financing that will need to support national allocation of resources. I don't know whether the panelists have had an opportunity just to sort of quickly look at any of those issues and want to respond to any of them. I don't know whether you're able to see the questions. Because the other themes that were answered in response to one's Laura's presentation was highlighting that practice is essential, not just academic knowledge. So this competency-based element, I think, is recognized as being important, but is perhaps not something that is evident in all training programs. So maybe highlighting, Laura, first of all, the difference between a master's in public health knowledge-based training program and a competency-based training program. Perhaps that's a question you could touch on first of all.
Yes, thank you so much, Neil. There are some incredible, interesting questions and comments, and thank you very much for everyone to engage on those. So I think that as educators now, we are realizing that the continuum now of educating in public health has just grown tremendously, because now we need to start talking about not even just like undergraduate, graduate, and then of course lifelong learning, which is the whole workforce, but also beginning even before that. And we have been seeing really experiences around the world that they are starting to work in public health 101 since in higher, not only higher education, but even before that, even we need to actually start in primary, like K to 12, right? But aside that, I think that if we can concentrate on the undergraduate to the workforce development, we need to strengthen more the academic and practice silos. We used to work very silos before. Now we need to just stop that and just start thinking about what are the things that make sense to come together as a workforce, public health workforce people, regardless if you're in academia or in the practice side, in order to see what are the competencies that it needs to be, way to develop in the workforce. And those competencies should be not just knowledge-based, not just scientific-based, which of course still very important, but also practice-based. What are the things that in the practice, in the operation of the public health functions, we need to really invest and really equip the workforce. So it's a combination now. It's a combination of just science and evidence-based, which we will always be in favor of, but also the practice side, the incorporation of what they are really doing in the workforce. And I think that that's why it's very important to look at in the lifelong learning lenses, because now that's going to be our approach. So I think that the workers should be allowed to come up to return to education or to the schools and programs and even beyond that to the just educational pathways in order to just keep on upscaling their competencies, because that's our new normal. Our new normal is that you need to really keep on learning. So what are the avenues they're going to have for that? And that's why, of course, accreditation, of course, schools and programs is very important, but also what are the certificates that we're doing, the accreditation that we're doing when you are on the job, in order to keep on just learning. So it's just a combination and a balance between the practice and also the competencies-based education, which we try to really reflect on the roadmap. In the roadmap, you're gonna find that that growth scope of work there.
Great, thank you. I'll just quickly turn to Kevin next, if I may, because obviously we had a video recording of you, but it'd be good to hear from you in person. And I'd particularly like to ask about the experience of the Faculty of Public Health developing multidisciplinary competency-based training, and the support really that and the ways in which the faculty as a professional body works with academic institutions and also works beyond or between these different public health groups that you highlighted, the core, the allied, and the wider.
Great, thank you, Neil, and hi everyone. So yes, the Faculty of Public Health has been a leader among the medical royal colleges in the United Kingdom in really taking a much more expansive view of the training of public health professionals, moving beyond the medical model and integrating and supporting a multidisciplinary pathway for postgraduate training in public health. As many of you know, we have a structured postgraduate program, a 5-year program which includes a master's degree in public health, and then a competence-based training which allows our postgrad candidates to obtain different experiences in the various pillars of public health practice, but also to demonstrate their competence in those different areas as they progress through their training. So the key pillars include competences in health improvement, competences in data, knowledge and intelligence, competences in health protection and health security, a focus on health inequalities, leadership, and many other core public health competencies. So it's a very structured way of doing that postgraduate multidisciplinary training that we have for public health professionals. Now, we're keen to ensure that we have sufficient pathways in the UK for us to meet the needs and increasing demand of public health practitioners. So although the faculty has this structured approach to training, we also work with other bodies such as the UK Public Health Register, which allows for people who want to become trained in public health to become registered as professionals and practitioners through a competence-based program. So again, by getting different experiences, getting those experiences accredited, there's an opportunity for them also to have the final accreditation as a public health professional. Finally, a third strategy for us is really ensuring that we're widening the tent for public health, people interested in public health, and developing new strategic collaborations with other professional bodies so that we can think about how we both embed public health competencies and skills across professions, but also how we dual train and dual accredit other professionals as well. So for example, I'm really excited about the relationships we've developed with environmental health practitioners to ensure that their role as a key part of the public health family is solidified and we have relationships with them. We're just starting an entirely new training program for general practitioners who want to be dual accredited in general practice as well as in public health, and that will be a single unified postgraduate program for those medical practitioners who want to be dual accredited. So in summary, Neil, I think there are a number of strategies we are using at the moment with the objective of widening the tent of public health practitioners. They all are based on competency training. They all are based on a defined series of competencies and skills that people have to develop, and at the appropriate points to receive their accreditation. And while doing that, building strategic partnerships to ensure within general practice, environmental health, and others, we're bringing others into the public health family. So Neil, I hope that gives you a sense of what we're doing in England. It is a journey that we're on. It feels as if we're never at an end point. We're always looking at new opportunities to expand partnerships and to collaborate with our training.
Brilliant.
Thanks.
Yep. Thank you very much. And I'd like to just turn to Dr. Mollant now, if I may, because clearly Papua New Guinea has made huge strides with the workforce, but you also face a number of challenges, as you've highlighted, with there being insufficient numbers of workers available. And I suppose there's a question of when you've got a limited workforce capacity because you haven't maybe been able to fill all of your posts, how do you manage to deliver the essential public health functions? And does it mean you're asking a huge amount of very few health workers and expecting them to do an awful lot? And how can we support individuals under a lot of strain?
Thank you very much, Prof, for that question, and thank you, colleagues. I would like to say that in any difficulty, there is always a solution. So one thing is to, first of all, map the key health workers, know what they can do, what is the core skill that they must be preserved to do, so that the other core pieces of work or tasks that can be undertaken by others are tasks shared with the others, number one. Number two is engagement of the communities we serve. The role of communities is very critical in reducing the workload to health workers. So that is why we have a new cadre called the Village Health Assistants. If you look at the WHO vaccination, you'll see Papua New Guinea is one of the countries with the lowest vaccination rates, I think 10 to 12% only, including the healthcare workers. So the work of the community is very important. With these village health assistants are community-owned resources with limited education. Like you have seen, the literacy levels are very low. So you tailor-make the information that they give to the community so that we handle the issue of prevention. So it is a very difficult situation, but again, it is easier As we work towards, currently we are working towards training more health workers, but the few that we have, we are adequately optimizing their skills so that they are multi-skilled, and we're just giving the competencies for the key core competency from the roadmap that can support in addressing some of these challenges. And I think the more the challenges are, because today there is a hurricane, tomorrow there is a landslide, tomorrow there is an earthquake, there is these climatic changes, they are frequent. So the communities and the various sectors, in fact, we engage even security. Some of the armed forces join in, so they have extra skills beyond the health workers for such circumstances. So it's a whole people approach towards that. And then I've seen a question that kind of I want to answer as I handle this on what are some of the things we can do to manage harassment of health workers. PNG is one country where health workers, the reason why they left the pandemic very weak and tired and willing to leave the profession is because they were affected. Some of them had their homes burnt down because of the vaccination, that there was very high resistance to vaccinations. So they lost their property, they were attacked. Some of them went into safe houses during this time. So in the recruitment of the 7,000 health workers that we had, 500 positions are left for the police security. So in some of those pockets, areas where the health workers are insecure, each facility has got a police post attached and policemen around for purposes of securing. And the government has come out very clearly with a standardized zero tolerance policy against harassment of health workers, and services can be denied to such communities for a while. That's when they realize the health workers are very important. So that combined approach from the government, the security system, enables the protection, prevention, and promoting good relationship with the communities. The communities become the first line of protectors of the health workers. Thank you.
Incredibly important points, and I noticed there were some questions earlier on about sort of how our communities engaged in the whole workforce development process, and I think you've beautifully illustrated the partnership that needs to exist between public health and community if we're to achieve public health. So Carla, I'm going to turn to you next. There were some questions on, you mentioned the 3 types of FETP. There's been a comment on the cost of training FETP and whether you would recommend phasing out in the rolling out of FETP. So do you train all 3 levels at once, or do you start with the lower level and build up? Is there a particular approach that is recommended?
Yeah, thank you. Thanks for the question. Neil, with the pyramidal training model for countries that do not have an FETP, it is advised that they start with the lowest level of training in the pyramidal model, that is the frontline training. I mean, in terms of cost, what frontline does is it keeps trainees in their jobs, right? It's a 3-month training. It's roughly 2.5 to 3 weeks of face-to-face contact time over a 3-month period. In the time in between the face-to-face points, the trainees go back to their workplace and do a work-based project, a group project. So I think it's a very efficient, effective way of starting, FETP training in countries where it doesn't exist. Also, the pyramidal model serves as screening. So from cohorts of frontline that are trained, you can actually sift out those that are interested and available in pursuing when the country finally institutes the next level of training, which is the intermediate. So that's what common practice is, and that makes sense, actually.
Excellent, thank you. And then Juan, just to bring you in, I mean, I know you'd asked questions about for how WHO can adapt. I think there were some replies that came in the question and answers, but maybe you can tell us a little bit about what you're currently doing to both make the tools and documents available and then to adapt them to country-specific needs as WHO.
Okay, thanks everyone. Thanks, Neil. And I would like to thank all the partners and team members. Actually, the roadmap implementation is a teamwork. And I can see my another colleagues, Catherine Kay and Lizzie Tenson, is helping us to reply the questions in the chat. So in our roadmap team, we have 5 working groups and 3 working groups. 1, 2, 3 is work on the 3 action areas. And another group 4 is working for communication, including knowledge translation and dissemination. It's led by Catherine Kay. And Lizzie and I, our other colleagues, is in the group 5, working group 5 for general coordination. And all our partners and stakeholders join at least one working group. And so our working group is expanding to a global level. So I would like to mention this one. And the second one would be now, as we mentioned, we are developing 3 technical tools focus on these action areas, provide specific technical support for the country implementation. And the 3 technical products are on the final stage of publication. It's expected to be shared next month or next 2 months, I think. And at the same time, we can see the roadmap as very broad issue. And we don't need our stakeholders in country or the colleagues in country to understand every detail of the technical issue. So we are developing a checklist. We call them guidebook. Very simple, just 10 or 20 pages for country to easily assess the point of our technical support, the available resources, the link to the detailed technical products. So we are also consider to finalize this process in the next 1 or 2 months to help our country. And the third point I would like to mention is, even if I cannot see each of the questions relate to us, I noticed one question repeat again about the pharmacy as role in the public health workforce. You can see several speakers share the same figure about the broad concept, broad scope of public health workforce, right? There are 3 groups of workforce public health. The group 1 would be core or specialized public health workforce, just like CDC, the organization work in CDC specialized. And the second group would be health and care workers, implement 1 or more public health functions. So the pharmacist would be included in this group. So the group 3 would be the wider health workforce or workforce beyond health sectors. So this is a very broad issue. So the multi-stakeholder cooperation would be the great challenge and would be the key to implement the roadmap. And I think this is what we are considering. And at the meantime, we are looking forward to reach out to the country level by 3 levels WHO network, or by the seminars like this to connect with any interest from the country. So I would like to say in the country level, the benchmarking is not necessary to start from the whole nation workforce. If it could be staff from a local level, provincial, state, or
Thank you.
unit system. So
Okay.
please send us the email by the SharePoint, the team email. We share in my PowerPoint. Thank you so much.
Okay, thank you very much. Yes, so I just turning now to some of the other questions that have been asked. There was some of them have been summarized, but there was questions about how do we move from the theoretical frameworks into practical action. I mean, I think we heard from Dr. Mollant the practical operational things that are being done. There were some very tangible examples that you gave, Dr. Mollant, of protecting health workers with the need for engaging with communities, a temporary, presumably police presence to protect health workers whilst that community action. But if everybody can think about the things that they're doing to translate action into practical delivery and what we do, so that this isn't just a theoretical discussion, but it links directly to things that can be done to improve the workforce. And maybe if you can all give an example or two of that. So Laura, can I start with you? Practical
Absolutely.
actions.
Well, one of the things that, let me share the experiences here in the United States, what we're doing through the schools of and programs of public health in each of the states is just strengthening our relationship with our local health departments. So again, before it was more like silos. Now we're trying at least just to do more proactive data connections and just offer our technical expertise to the schools and programs in order to work together with the health departments in order to put together the curriculum of the to update all the competencies of the workforce. So we have good examples right now in some of the states. That's not the success in all of them, as we all know, but in some they are really moving forward into more collaborative partnerships in order to really implement educational strategies. We are doing other things. For example, we are trying to train the basic workforce that was hired due to COVID-19. So these are people who they don't have any degree. They just were hired just to support the work of the local health department. So we're trying to understand where are they and what skills they have, even though they have a very few or maybe none in public health, and try to put curriculum based on the roadmap to just the beginning, the basis for that. So we are starting to see those connections there, but all started with really a proactive connection with the local health departments from the academia in order to make this happen.
Great, thank you. Kevin, over to you for the same question, but also if you can bring in something on lifelong learning and making that a practical reality.
Yeah, so I think we have two strategies, practical things that we're doing. So first is to continue to champion the role of public health workers, and the essential roles that we play both in the health and care system and wider society more generally. The Faculty of Public Health has just launched a new campaign, which is called What is Public Health? And through that, we really want to stimulate conversations about what we do and how we do it, to tell the stories of the day in the life of public health practitioners, to show the diversity of both practitioners, the work that we're doing, and the impact that we're having as well. So that is at the front end in terms of continuing to make the case for a strong public health workforce. And then the other end of the spectrum, Neil, is retention of our public health practitioners. As you know, with the pandemic, we have people who are exhausted, as we've heard from other speakers, who've chosen to work in different ways to manage their work-life balance, and people who are leaving the profession earlier because of the impacts of the trauma of going through the pandemic. So there's an element of supporting well-being of public health practitioners, and also thinking about their lifelong learning. So we continue to provide opportunities to refresh, opportunities to learn, opportunities to engage with networks to support their development over time. So a couple of practical things we're doing in the faculty, really thinking about the workforce and showing that we care about the workforce as well.
Excellent, thank you. And Dr. Molland, you gave us some very good examples. Is there anything else you'd say in terms of operationalizing this approach to workforce development?
Thank you. I would begin by saying that looking at the National Health Workforce Accounts, PNG has only a total of 39 public health workers in terms of purely training in public health. So we have realized we are a long way to go. So what we have done is tell every worker, the word is we are all public health workers. But the skilled ones have got a greater role. But all of us are public health workers, so that they look at it as a team-based approach as we work towards getting more of them, and a lot of training on the FETP going on at various levels, the basic to advanced, but everybody is grouped as a public health worker, so that we kill this idea of they are public health workers and we are not. That is one. And number two is for purposes of long learning, the new curriculum has been revised for most of the cadres to accommodate the competencies that we are able to pick from the roadmap. So we are very sure in the future we'll be having health workers coming out who are skilled, but again, while strengthening the public health core function again. Thank you.
Excellent, thank you. And a very clear message there that we need to expand this sense of this being a collective endeavor and making sure that everybody delivers the essential public health functions. So turning to you, Carl, I mentioned before the global field epidemiology partnership that TEFINET is planning to launch. Is that a practical next step to promote field epidemiology, or maybe you can give us some more details on the objective of that and what the hope is that that will deliver?
Certainly. Thanks, Neil. You know, I previously mentioned the field epidemiology enterprise, the conceptualization of which came out of those partner stakeholder meetings in Bellagio and Geneva. I mean, what COVID-19 has taught us very well is that it takes a broad range of responders, of public health workforce cadres to be involved in pandemic preparedness and response. Pandemic preparedness and response is not only the purview of field epidemiologists from FETPs. So the Global Field Epidemiology Partnership is an attempt to expand the scope of TEFINET and field epidemiology training beyond FETPs. I mean, FETPs is still the mandate of TEFINET. It's still our core business, but we've realized that there's other cadres of staff in ministries of health, in national public health institutes that need field epidemiology skills. They don't have to become field epidemiologists, but they need certain skill sets in order to be appropriately trained to detect and respond to pandemics. So yes, I would say that's a very practical step. And the GFEP, Global Field Epi Partnership, is now the effort that we are making to be more inclusive and to be able to train and incorporate these other broader cadres of public health workforce.
Great, thank you. And then there was another question on communication, and I think it was from Kate Tulenko. Hello, Kate. And it's good to focus in on how do we improve the communication, both amongst these different players within public health, but also between public health and clinical, and ensure that we're speaking the same language, joining forces to tackle sort of common issues and working effectively together. So approaches to strengthening communication would be something that would be useful to hear about. So Laura, if I start with you again.
Absolutely. I was thinking right now, like, what's the takeaway from just hearing all of you and just hearing our world right now? And I think that challenges always brings opportunities. And I think right now the opportunity is just like to work together, and communication is like essential. I mean, it's just like the number one thing is just how do we build trust among ourselves? It's just to communicate better among ourselves first, and then among our family, which is all the health professions, and beyond. Because I think that if we have failed to communicate our message, like the public health message to the community and to the world, I think we need to start thinking about what's the communication that we have in our family, right, first. And then if we improve that, I'm sure, we will improve then the communication that we give to the world. So for me, the main message is just like, we need to do a better job in communicating first among ourselves, and because all of us have a common agenda, but it's just the way we approach, and there's a space for everyone to really move forward the agenda. But communication and trust is key to this area. So I would say that.
Thank you. And Kevin?
Well, Neil, you know how much I prioritize communication. I think as public health practitioners, we need to get smarter and more familiar with digital social media tools to be able to tell our stories, to capture narratives around public health. We need to build partnerships with other medical specialties and to think about the win-wins in those partnerships so that we bring the importance of public health to the work of clinicians and that they become advocates for us as well. We've seen where policymakers are far more likely to listen to pediatricians and general physicians than they are to public health people. But if those clinicians are integrating messages on prevention and early intervention, it is even more powerful. So I think both using new tools for communication and capturing and telling our stories, and thinking about how we leverage our partners to also tell the stories on public health will be key as well.
Thank you. Excellent. And you'd raised questions about the role of artificial intelligence and the new data. And there was a specific question on whether that will be a benefit and whether everybody will have access to it. Do you see any particular challenges or inequalities that access to AI might create?
Well, like all new technologies, we expect to see the diffusion taking a particular pattern. The early adopters, the people who are both engaged, literate, and confident in using technologies, adopting them first. And then you have a long tail of others who will become engaged. The reality is that public health practitioners need to begin thinking about how we mitigate these inequalities, how we think about literacy and confidence in using the tools, and how we make practical applications of AI to population health. Because at the moment, Neil, I think there's a big focus on AI and clinical practice, and less so about how we use it to improve and engage population health and mobilize communities. So that's the space that I'd love public health practitioners to be in, to be driving the conversation rather than playing catch up with the conversation on AI, but also thinking about the drawbacks and the limitations as well.
Yeah. Thank you. Dr. Bolton, in your presentation, you highlighted some of the challenges which result from miscommunication and misinformation, with all of the negative attacks on health workers linked to a misunderstanding of vaccination. Is there anything that you want to say on communication and how to address some of those misunderstandings?
Thank you. I would say that indeed that was true in the case of Papua New Guinea, but I want to clarify that I think it's a lesson that we learned. During the crisis, we got a lot of support from the neighboring countries. Papua New Guinea is just a neighbor to Australia, just a neighbor to New Zealand, just a neighbor to the big giants in the neighborhood. So all help came, but nobody asked the community what they wanted. They all came thinking the country is weak, we have come to support, but they all resisted. And we ended up with the lowest vaccination. So when we picked up the new strategic plan, if you look at it, the key result area 1 is community engagement. The next is partnership. So those are very important things. They realized that the community we did not understand what the community clearly wanted. the indigenous members of the community did not understand why they needed the vaccination. So outsiders came and thought they were addressing the issue, but that was not their problem at that particular time. They just needed to understand. So my way of communication is from the eye of the community that I'm serving. I don't bring in my WHO intelligence or knowledge, but I pick it up from the eye of the community. With that, we get to understand a lot of issues. Now they are going for the vaccination beyond the COVID, simply because it is driven by the village health assistance. So let's look at it. When we support these countries, let's look at the context, get it from the eye of the populations that we are serving. Thank you.
Excellent, thank you. I think I lost you briefly there, but that sounds like that was a very, very comprehensive answer. Sorry, I dropped off for some reason, but I've rejoined now. So Carl, just turning to you on the same issue around communication and things that we can do to strengthen it.
Yes, thanks, Neil. You know, in a sense, well, TEFINET is a global network of these FETPs, right? And I mean, a network is about relationships, and relationships are about communication. So, you know, we really value communication. And, you know, we try via the TEFINET website and via TEFI Connect, which is our online platform for FETP trainees and for graduates. And we are on social media. So we use all of these to communicate and provide opportunities for our members to communicate. On TEFI Connect, our trainees and graduates have chat groups in different languages on different themes. We regularly put out newsletters and updates and items of newsworthiness, you know, all in an effort to communicate. So yeah, I can't underscore the value of communication. Also, to Kevin's point, you know, during COVID-19, many FETPs had to pivot from traditional face-to-face classroom learning to online learning, because clearly people were isolated and not able to come in. Some FETPs were actually overwhelmed with COVID-19 response and suspended teaching for a while. And those who continued teaching used online mechanisms and virtual learning. So that pivot, that switch had to be made, you know, so hence the value, obviously, of digital learning and online learning, and communication obviously is key. And as you've seen, TEFINET has been a partner and participated in all those workforce development efforts led by Jim Campbell and by Kasum Diallo and other partners as well.
That's great, thank you. And Juan, you've already mentioned the communications work that is so central to WHO, and I know Catherine Kane is a part of the team and has been engaging heavily in responding to the chat questions. So I know this is something the WHO is very committed to. I'm about to start wrapping up, but is there anything you briefly wanted to say on communication before I move to the close?
Yeah, just one point I would like to add. Communication, the demand of communication is increasing. So the communication channel will depend on the target population. So our colleagues, you mentioned Catherine K, is the technical lead in the communication working group. So just stop here. Thank you so much.
Okay, thank you. Well, I would very much like to thank our speakers for the session today. And just briefly to summarize the journey we've taken, we've understood that the workforce has been, the public health workforce in particular, was truly tested by the COVID crisis, but it's been an opportunity to emphasize the importance of building a public health workforce that is capable not only of responding to future epidemic or pandemic threats, but of delivering the full range of essential public health functions. And we've heard about the roadmap that WHO has developed with a number of partners in order to strengthen the public health functions, their delivery. That involves mapping and measuring the existing workforce, looking at the skills and competencies and who possesses those across a wide range of diverse public health workers. And it involves, yes, then training and developing that sort of capability. We've heard about WHO's roadmap and its ambition to reach 100 countries. And then we've heard from Papua New Guinea, a country which faces a number of public health challenges, but has embarked already on the process of mapping and measuring, looking at its data and understanding its existing capability. We then heard from sort of Kevin Fenton, President of the Faculty of Public Health, how systems are developing rapidly to sort of respond to public health crises, and we need to make the most of new opportunities and challenges that come with AI and other technologies, and ensure that we deploy them effectively. We've had a very interesting series of questions and answers as people have explored the 5 questions that were posed. This session has been recorded, and there will be, I think, many of the answers to some of the questions have been put in the Q&A session. So hopefully people will have a chance to sort of read some of the questions that we haven't been able to answer directly. So I'd very much like to thank the NHS England and WHO for organising this session, and to really hope that all of you as country representatives will take up the challenge of mapping and measuring and developing your public health workforce and promoting competency-based training as we all strive collectively to build our public health capability to face future challenges, which might be further epidemics or pandemics, but are most likely to be the everyday challenges that we face in public health of addressing inequalities and responding to non-communicable diseases. There's a broad range of activities that public health needs to address, and we need to ensure that we are collectively capable of delivering the full range of essential public health functions. So thank you very much to all of our speakers, and thank you very much to the organisers for the event. I think there will be an online evaluation questionnaire that comes out following this, and access to the materials that have been shared by the speakers. So please do respond to the online evaluation when that comes through to you. So thank you, everyone, and that's been a great session. Thank you and goodbye.